Hi, everyone. I'm going to get started. Thank you all so much for coming. I'm Mary Gallagher. I'm the director of the International Institute, and I'm also a professor in political science. I'm really happy to be joined here for the second International Institute Roundtable of the year. This is a format for the II community to gather across our multiple centers and programs to discuss issues of global concern, and the COVID-19 pandemic is without a doubt one of the most consequential global issues we've experienced in our lifetimes, like climate change or world war. It's affected each and every one of us. We're very happy to host this roundtable and also to have supported the open access publication of the book. That'll be the focus of the roundtable: Coronavirus Politics, the Comparative Politics and Policy of COVID-19. The book is now available in print and electronically. It is open access. Before introducing our two moderators today and two of the four co-editors of the book, I'd like to briefly thank our co-sponsors: the Center for Southeast Asian Studies, the Center for European Studies, the Weiser Center for Emerging Democracies, the Center for Russian, East European and Eurasian Studies, the Weiser Center for Europe and Eurasia, African Studies Center, and the Center for Latin America and Caribbean Studies. I'd also like to thank Derek Groom, who's working behind the scenes with logistical support and planning, and Rachel Britka and her team in communications for the publicity. Okay, I'm going to introduce our two moderators today. Scott Greer is Professor of Health Management and Policy, Global Public Health and Political Science at the University of Michigan. His most recent books include Federalism and Social Policy, Everything You Always Wanted to Know About European Union Health Policy But Were Afraid to Ask, and the European Union After Brexit. Scott is a faculty associate in the Center for European Studies. Second moderator is Elizabeth King. She's an associate professor of health behavior and health education in the School of Public Health at the University of Michigan. She specializes in the structural and social inequities influencing access to HIV services, women's health, and gender equitable access to healthcare services, the promotion of a rights-based approach to HIV testing and treatment policies, and the influence of global policies and funding on public health in Eastern Europe and Central Asia. She's a faculty associate of both the Center for Russian, East European, and Eurasian Studies and the African Studies Center. I'm really glad to be here today to welcome you all, and I'm going to pass it over to Scott and Liz. Thank you so much.
Thank you, Mary, and we're very grateful to the International Institute for supporting open access and for hosting what I think is going to be a very fun event. So we're very grateful to all of you for this and to the centers that we're co-sponsoring. And since I'm the person who drew the unlucky job of having to close people down in order to keep us all to 5 minutes, I have a lot of incentive to actually not be too verbose in the introduction that I'm doing here. So these are the speakers that we have. Out of the 67 people involved in authoring the book, these are some of us who have an active University of Michigan affiliation, and I'm delighted to see some of the other authors in here. For those of you who'd like a free 654-page analysis of the first wave, click on that shortened link. We'll also be putting it in the chat. And if you want a hard copy, use the discount code UMS21. Now, this was actually born at an International Institute party in February for somebody who's actually one of our authors, Margita Metska. And Elizabeth and I and a couple of others started talking about how it would be good to go to Rome in autumn of 2020 and present on the politics and what we learned about policymaking from a fairly rough spring and summer of 2020. We thought of some ideas and we went to lunch and worked it out a little bit more. And we even went so far as to say maybe it'll affect a number of other European countries. And we should put out a broader call for people who'd like to attend the European Public Health Association in Rome in October. Well, as you know, the pandemic got a bit out of hand relative to that. And the book accordingly also began to expand as it hit more and more countries. And we found more and more interesting people with interesting and often unreported or poorly reported country experiences. And so this is the short group of people that you're going to be hearing from during the panel today. But I want to just briefly tell you how many people and countries are covered in this book. So, Elizabeth? So We start off with the World Health Organization and Holly Jarman, who you'll be hearing from today about public health, and then we take it into global case studies, roughly following the virus around the globe, which means, next slide, please. Oh, which means China, Hong Kong, South Korea, Vietnam, Japan, Singapore, India, Kazakhstan, Kyrgyzstan, Uzbekistan, the UK, the European Union, which had an interesting story, Denmark, France, Austria, Germany, Austria, Switzerland, Italy, Spain, Portugal, Italy, Greece, Turkey, Czechia, Hungary, Bulgaria, the Russian Federation, and then over to the Americas for Canada, the United States, Brazil, Colombia, Chile, and finally to Africa, where we have Malawi, Tanzania, South Africa, Egypt, and Nigeria. So this is a lot of countries. And we attempted to organize the book around some hypotheses that we thought they would all fill out together, and we discuss in the introduction. So back in March 2020, here's what we came up with, and which helped structure the chapters and the analysis. The first one, and the big one, is that social policy matters to crisis management as well as recovery. There's a strong tendency in sort of common sense, as well as in a lot of public health and emergency response thinking, to separate social policy from the actual pandemic response, to effectively think that you lock people down or you do some other public health intervention, and then you think about the consequences for their businesses or their lives or their equality or status in society. And we argued that it's wrong. Not only are there enormous costs to be allocated during and after the damages, a lot of public health measures depend on social policy measures to support them. You can't just wall people up at home so they'll starve. You have to understand the contexts that allow people to comply with public health measures, such as giving people paid time off to get a vaccination seems to be a good policy at the moment. There are inequalities during and after the pandemic. These vary from country to country, but they tend to follow these patterned lines of problems. Which populations systematically are mistreated by the political economy, which populations have the best chance of having their particular needs and claims rewarded by the political system. In making these decisions, political systems matter. And while they changed in exciting ways during the pandemic, I don't think 2 years ago anybody would have thought Sweden would be the darling of the world's libertarians. We thought there would be a couple of consistent themes from political science that would help explain government response. One of them is regime type. There's a lot of work on comparative authoritarianism, quite sinocentric, which points out that information flow is a problem in authoritarian regimes. You lie upward if you're a bureaucrat in China. And for authoritarian regimes, everybody expects them to lie to the population, which means that there's a problem with trusting public communication. Against that, only some authoritarian regimes can and will act effectively. We've had some, and featured today, which actually did a really good job of stamping down on the problem with classic public health measures such as quarantine and contact tracing. But every one of those is matched by several which did not turn into a performance that was a credit to authoritarianism relative to democracy. Within the democratic and hybrid regimes, we picked out two kinds of formal political institutions that matter. Federalism, which creates coordination problems, but also potentially increases resilience. We're hosting this in Michigan. For much of 2020, the Michigan state government was able to cushion the effects of the inept federal response in the United States. So there's some resilience, but there's coordination problems, variation, and new forms of politicization that you get. The other is presidentialism, which is having an independently elected president who's hard to get rid of. This creates two independent power bases, one of them with control over the executive, the other legislature. And most of the work on presidentialism has been qualifiedly critical of that as a way to set up and run a country. But very little of it is about what happens in public policy. And what we discovered is the politics of agency, the empowerment of a president, increases the risk that Emmanuel Macron or Donald Trump or Jair Bolsonaro will make a mistake that really matters to people. The final one is that state capacity matters, that having it isn't the same as using it, though. You can have a very good state capacity, as many European and American countries do, and not deliver a particularly good public health response with it. And in particular, that investment in a specific set of public health institutions, such as CDC, and they're often modeled on CDC, might not matter. It might not be the right capacity. It might matter more to have a general fungible bureaucracy that you can turn to any issue that comes up. So those were the hypotheses that kind of structured the book and we had in the back of our heads. And our authors quite delightfully turned their expertise and thinking to helping us answer those questions across the board. And now I'll pass it over to Holly Jarman, who is going to speak about some of the public health patterns that we saw. Holly Jarman is an associate professor of health management and policy at the University of Michigan School of Public Health. She is a specialist in trade policy and politics, public health policy and politics, and has been working extensively with the US government and the World Health Organization on responses. Take it away, Holly.
Sure. You promoted me a couple of weeks early, but I'll take it. So hopefully that will be true within a week or two. It was actually quite hard to write this chapter. When you look at the slide, it looks so simple. One of the things I was trying to do here is looking at the different country chapters coming in and trying to think about the ways in which we could seek to understand state responses in a comparative way. So what were governments doing? And then obviously you can see on this slide, I'm concentrating a bit on some of the things that they did that resulted in increased spread or increased damage from the pandemic. But then also looking at, in this chapter, at the political side of things. So what does that mean for the integrity of the state going forward? If the state is a democracy, the democratic nature of the state going forward in the context of these public health measures. Because a number of these measures were quite strong and distinct, and something that even public health people hadn't necessarily done on this scale in a very long time. So the key thing here is that states had to do so much right in order to control the spread of COVID. And I'm going to talk about this in the context of 4 different categories of activity. If you want to know more about any one of these, please do go read the chapter. But states only had to do a very few things wrong in order to see a bad result. And I think then that's part of trying to think about the context of our study, which looks at the first wave of lockdown and the first 6 months of 2020 in the context of some of the things that have followed and some of the lessons we might be able to draw from that. So here, I think a good way to think about comparison and think about the case studies that you're just going to hear in a couple of minutes is to think about governance, surveillance, coercion, and social policy. So governance being how a society is steered by the people in charge. And in particular for this pandemic, leadership did matter across these cases. The signals that leaders put out there into the world, whether that was wearing a mask, getting and being seen to show precaution, whether it was in their speeches and rhetoric, whether it was in terms of timely decision-making and policy advice coming out of central government, but particularly in terms of the central executive, that made a difference in the success of countries in this first wave of lockdown. And so at the top of government, leaders had to do a lot. They had to make clear decisions, consult experts, and they all decided to consult experts in different ways, and some decided to sideline experts in public health or medicine. They had to be signaling to the public, and some of them chose to do this, that we're all in this together, and if we proceed to lockdown, we'll be able to control the spread of disease. So where this broke down quite often across these cases, partisanship was in the picture. In particular, some of our countries, there was populist movements or parties with a strong populist tendency, which meaning that there was quite often a reluctance to believe in or support public health evidence. And so sometimes that led to absent or negligent leadership, and where you start to see that leadership or relationships between subnational governments and national leaders break down, that's where some of the problems started to occur from a political perspective. The second category is surveillance. And here we're talking about specifically public health surveillance, trying to get a handle on the scope of the pandemic, the number of cases, the consequences and severity of the pandemic in terms of hospitalization, in terms of mortality, and also in terms of equity. So here governments had to do quite a lot to bring data together and then try to have a process to act upon that data. And so a lot of them chose to create new structures or supplement their public health system in terms of surveillance in some important ways. A big thing that countries did wrong here is to open up restrictions after the first lockdown without adequate contact tracing and testing in place. And you can see that in the countries that never really quite made it to recommended thresholds of testing and did well in the first lockdown, but because they didn't have testing and contact tracing in place, they weren't really controlling the spread. And it's important to note that a lot of these lockdown interventions are not designed to be used in this long-term way that we have seen during the pandemic over the last year. Really, the idea was to do this in a temporary fashion, have a strong lockdown, and then build up the public health systems that you would need around testing and contact tracing over time. So the third one here is coercion. And there's a really specific set of reasons why I'm painting this as coercion. It's not just use of government authority to try to control what individuals are doing and what they can do in society and what organizations and businesses are doing. And so here countries adopted a range of policies designed to close down high-touch businesses, for example, or ask people to stay at home or wear a mask. And then in the specific cases of exposure, they're also requiring people to isolate. So some of the failures here, the problem here is you're using government authority, and so where government authority is used in an arbitrary or unjust way, this can cause a number of serious problems. Alternatively, some other countries had a clear policy, but it wasn't really enforced, or it was enforced very unevenly across the country, particularly for some of our federal countries. So on both sides of the scale, there are severe democratic questions, there are severe questions about personal freedom, but also questions about what would be effective in terms of a public health response during the pandemic. Finally, social policy. Some examples here are income replacement or expanded healthcare access, as well as sort of trying to support the rights of employees who might be vulnerable and find themselves in a situation where they need to have a modified work environment. So some countries did a good job of some of these social policy structures, particularly those countries who already had some of these structures in place, the ability to a well-designed income replacement scheme, for example, whereas other countries didn't necessarily have those policies in place or didn't have the capacity to put them in place, or political opinion and partisanship led them to not really go all in on social policy in a way from a public health perspective we would want to see. Another mistake that countries made was ending those policies too soon. And I'll emphasize what Scott said here. Really, the contribution of social policy in terms of being able to keep people at home, ensure they had healthcare access, and you can't comply with a lockdown or other measures if you have to go out and earn a living, and there's no bandwidth or government or other social support that comes in to fill the gap. So I hope you can take some of this framework in your heads and take it through as you hear these next country cases. I'd be happy to answer some questions on any of this in the Q&A. Thanks a lot.
Great. Thank you, Holly. Our next speaker is Michelle Falkenbach, who's a PhD candidate with the Department of Health Management and Policy here at the University of Michigan School of Public Health. Michelle's research interests include populist radical right politicians and their impact on health politics and policies, comparative health policies, and European health systems. Michelle?
Thanks so much, Elizabeth, and thank you all for inviting me and having me here today. So I'd like to talk a little bit about Italy. Obviously, if this is just an overview, so if you'd like more information, it's all in the chapter. So what I want to start with is what actually happened. And Italy was the first country in the European Union really impacted by the coronavirus. That's kind of where it started. And the virus spread very quickly, specifically in the northern regions. And Italy was pretty much always in the top 10 rated worldwide of number of cases and number of deaths. And what this came down to, or why this kind of happened, is that public health in Italy was underfunded for years. And in combination with that, the Italian government, as most governments I'm sure we'll hear, was unprepared for the pandemic or a pandemic of this magnitude. And in addition, which was unfortunate for Italy, the government was also very inexperienced. But before I touch on these points a bit more, I'd like to tell you three things that are really crucial to understand when thinking about the Italian healthcare system or healthcare in Italy in general. The first is that Italy falls under sort of the beverage model of healthcare, if you will. So it is tax-based and it's universal and it's free at the point of care. A really important fact in Italy is that healthcare is decentralized. So what that means is that there are 21 politically and operationally autonomous regional healthcare systems in the country. So essentially, there's 21 different healthcare systems in Italy. And because of this fact, each region essentially had a different strategy as to how to fight the pandemic. And I'd be happy to go more into this in the question and answers. The third point is that the northern regions were substantially better equipped to deal with the pandemic compared to the poorer southern regions. And thus one of the biggest sort of strategic goals that the government had was to keep the virus from moving south. So back to sort of what happened. In terms of public health, I mentioned a severe limited investment in public health. So this touches on Holly's point of surveillance. In many regions, this was a severe problem. And if you want to kind of know the differences between the regions and what strategies they adapted across the country, these are all highlighted within the chapter. But what does limited investment in public health mean, and what impact did that have during the pandemic? Well, there was a lack of medical equipment, which I'm sure was broadcasted in most news outlets worldwide. With regards to Italy, there was limited availability of acute hospital care because a lot of hospitals had been closed due to severe cuts in health expenditure. And because obviously of the limited acute hospitals, there were also a limited amount of beds available. In addition to that, there was not enough medical staff. And so people had to be brought out of retirement actually to help during sort of the peak point of the pandemic, because there were simply not enough nurses, doctors, carers to take care of people. And again, this is very regionally different. So some regions had more of a problem than other regions. Moving on to the next point, the pandemic plan. Italy did have one, so plus points for that. However, it was very outdated. It was practically never used, and thus all the procedures had to be reinvented during the pandemic. Another big problem, and this is something that Holly touched on under the point of governance, is that there was a really long period of denial by the leaders. So by the government, by the regional government, by the ministers. They just really kind of took too long to change gears and get serious about the pandemic. And that's sort of why these catastrophes happened in the Lombardy region, and why these pictures of the city of Bergamo, which I'm sure you've all seen, with the trucks of dying people or dead people were being driven to graveyards. So that was sort of the result of this really long period of denial until people sort of shifted gears. The third point, sort of from this public health perspective, is that the ministers were not experienced. So this was a very new government. A lot of the ministers in the Italian government had never held office before. And the result of that was that technocrats were called upon to help sort of the government out of stalemate, and also sort of make really important decisions. Just to finish up social policies, the aid packages were very, very generous, despite the fact that Italy was in massive debt. The problem with the aid packages was that there were long administrative delays until the packages actually arrived for the people. Thank you.
Great, thank you, Michelle. So moving to our next speaker, Dr. Pauline Jones is a professor of political science here at the University of Michigan. Her scholarly work contributes to the study of institutions and identity-based mobilization. Dr. Jones focuses primarily on Central Asia and has published 4 books and dozens of articles in both academic and policy journals. Dr. Jones founded and currently directs the Digital Islamic Studies curriculum, a collaborative program of instruction that provides a global perspective on Islam and the Muslim world. Pauline?
Thank you, Elizabeth, and thanks to both of you, to all of the editors of this amazing volume for inviting me to contribute. I'm always so thrilled when Central Asia is part of the mix. So this is a chapter that's co-authored with Professor Elizabeth King, and it focuses on 3 out of the 5 Central Asian republics. They're former Soviet Central Asian republics, I should say, part of the former Soviet Union or Eurasia. We focus on Kazakhstan, Kyrgyzstan, and Uzbekistan. And there's a couple of different reasons for focusing on these countries. First and foremost, they're very different when it comes to, or distinct when it comes to state capacity, including both administrative and fiscal capacity. They're also distinct when it comes to regime type. I can say more about that in the Q&A if people are interested. You're sort of looking at this variation, and despite this variation, they implemented very similar health policies and very similar social policies. So that was striking to us. They also instituted policies that were very distinct from their counterparts in Tajikistan and Turkmenistan, the other 2 countries in this region. Those 2 countries, similar to what Michelle was saying, in those 2 countries, the leaders essentially denied that the virus even existed and refused to place restrictions on businesses or individuals, any kind of social distancing policies, et cetera. So in Kazakhstan, Kyrgyzstan, and Uzbekistan, what happened? Well, as I said, they did implement swift and comprehensive health policy responses. They closed their borders early in March, even before the first case was diagnosed in Kazakhstan, closed their land borders, canceled flights, closed businesses, closed schools, and they canceled all major holidays and celebrations. Only in Kazakhstan, Kyrgyzstan, and Uzbekistan, not in Tajikistan and Turkmenistan. So Nowruz was canceled, Victory Day was canceled. These are really seminal, Ramadan, Easter, no public celebrations at all. And these are really seminal holidays in the region. So it's quite striking that they did that. In terms of social policy, the record there is more mixed. But again, very similar. They offered cash payments, some of which are said to have not reached people in less administratively weaker cases like Kyrgyzstan. But even in Kazakhstan, there were some issues with these cash payments. The social policy in and of itself is not what I guess encumbered governments to then relax policies, which they did, even though they instituted these very comprehensive restrictions in March and April. By May, they were already lifting these restrictions. They lifted them far too soon. Yes, without the types of policies that Holly mentioned that are really important, and without the social policies in place. But it wasn't because they were too weak to continue, I think, but rather because they were ambivalent. Given the weak social policy, they were ambivalent about the economic consequences of these restrictions, the economic consequences on businesses, on individuals, and at the country level. So what happened was you had a so-called a second wave, a resurgence. I say so-called because I think it was just the first wave was continuing. It never sort of stopped. It was just on the uptake. And the lifting of these restrictions coincided with and contributed to, for sure, this huge second wave that took place by early June into mid-June, when these countries finally decided, all 3 again, that they needed to reinstate these restrictions. And they did reinstate these restrictions. But again, it was too little too late, because their healthcare system, which is incredibly weak, was overwhelmed. They not only didn't have PPE and sufficient numbers of medical workers, they also just didn't have enough hospital beds. So I think that the cautionary tale the Central Asia tells us is the state has to be less ambivalent about enforcing policies that are A, largely unpopular, and B, can have a huge social and economic cost, which is part of the reason they are unpopular. And social policy will only get you so far in terms of addressing those issues. There's also this issue of the fiscal capacity of the state in general to sustain an economic downturn, even an oil-rich economy like Kazakhstan. And there's this issue of poor health infrastructure, that if these restrictions are lifted too soon, in the context of poor health infrastructure, the consequences will be much worse, much more devastating. So thank you.
And thank you, Pauline, for a perfect 4-minute, 40-second. That's the organizer's dream. I'd like to introduce our next speaker, who is a co-editor of the book and a dear friend. She's assistant professor of public administration at the Sao Paulo School of Business Administration of the Getulio Vargas Foundation, FGV. She's also a visiting scholar at the Latin America and Caribbean Center of the London School of Economics. She specializes outside disastrous global pandemics in pharmaceutical regulation in Latin America, health industry policy, and the politics of infectious diseases such as HIV and AIDS. And she's currently funded to do research on COVID-19 by the FABESP, the Sao Paulo State Research Agency. She is Elise Massar de Fonseca. Take it away, Elise.
Thank you. Hello, thank you so much. Let me first thank Scott and Elizabeth for inviting me to be part of this amazing project. It's such an honor to be here today with these great authors and colleagues. Before I start, I want to acknowledge my co-authors, Nicole Natras from Cape Town University, Luis Arantes from FGV, and Francisco Inácio Bastos from Fiocruz. I'm sorry about the noise here. I wasn't expecting that. So Brazil is a very unhappy country, as we define in our book. At this point, I'm sure you all have heard about Brazil's tragic and disappointing response to COVID. Brazil is the third country with the highest number of COVID cases in the world, and the government has failed to implement a plan to prevent the spread of the virus. Actually, the disease today remains uncontrolled in Brazil. And what is more puzzling about Brazil's case is the fact that the country was somehow well prepared to deal with public health crisis. It has one of the largest public health systems in the world. Brazil is also famous for the HIV and AIDS program, the primary healthcare program. So the question we ask is, what went wrong? And we talk here about weak public health policies. And I'm going to give you some examples. One, and perhaps the most famous one, is denialism. The federal government, the president himself, minimized the pandemic, saying COVID was a small flu. We also had a lack of coordination at the central level. Brazil never had a comprehensive testing strategy. And I could go on with several other examples. And there are other examples in the book as well. On the other hand, Brazil adopted a strong social policy. And Congress approved an AIDS emergency package to support informal workers, families, and the unemployed. But and by doing so, it lifted millions of people out of poverty. So what explains Brazil's policy outcomes? I'm going to focus here on 2 points, reflecting on the hypothesis that we designed for the introduction of the book. First of all, Brazilian presidents are very powerful. I will not be able to get into the details of Bolsonaro's constitutional powers, but one example is the power to appoint Minister of Health, and president does not need Congress approval to appoint the bureaucracy. And in the past year, Brazil has had 4 health ministers, and the president has a strong saying in health policy decisions. He in the past year, he advocated for ineffective medicines. He interfered in the disclosure of official COVID data. He also complained about social distances, as if social distancing was damaging the economy. And more recently, he's also sowing doubts about COVID vaccines. As a federal country, and because of the inaction of the federal government, states ended up implementing measures to contain the pandemic. If we had lockdowns and campaigns supporting the use of masks, it's thanks to the action of state governments. But state governments took the blame for this, promoting these unpopular decisions. I won't be able to get into more details here because we have a short time to give our presentations, but I want to close saying takeaway message of our book is that politics matter for pandemic response. Actually, our book explains why politics matter. And I think Brazil exemplifies very well what is that. And I'm gonna leave it here for now. And thank you all again. I hope I used my time correctly.
Yes, perfect, Elise. Thank you very much. All right, so next on our agenda, I have the pleasure to introduce Kanayo Ogojuba. Dr. Ogojuba is a development economist by training with interests in behavioral research, population health, economics, and public policy. He has a long history of work with multilateral institutions with a focus on development policy. Over the course of his career, Dr. Ogojuba has played significant roles in cross-institutional collaboration, research development, and innovation activities. He is currently with the School of Development Studies at the University of Mpumalanga, South Africa, and I'm also excited to announce that he will be joining us here at the University of Michigan in the fall as an incoming member of the UMAPS, or the University of Michigan African Presidential Scholars Fellowship. So I'll turn it over now to you, Kanayo.
Thank you very much, Elizabeth. I'm happy to be here, and thanks everyone for coming on board. Quickly, I just want to highlight something before I go into what happened and why it happened. Although the number of COVID cases and fatalities in Africa may seem comparatively lower to Europe and the US, the looming health shock of COVID-19 has already adversely affected the continent's already stressed health systems, and if not managed properly, could quickly turn into a social and economic emergency. So beyond even the health jeopardies that we already see, the COVID-19 shock to African economies occurred in 3 ways quickly. One is a lower trade and investment with China in the immediate term, a demand slump because of the lockdowns in Europe and the US, and a continental supply shock, which has affected domestic intra-African trade. So going to what happened, both countries, why did we choose, before I go into what happened, why did we choose South Africa and Nigeria? We looked at the probability of African countries contracting this COVID based on the volume of air travel from the provinces in China to Africa. And we saw that the proportion for Egypt, Nigeria, South Africa, and Nigeria were very high. So we narrowed our focus for the chapter on South Africa, Egypt, and Nigeria. But I'm quickly going to talk about Nigeria, what happened with South Africa and why it happened. While Nigeria was the first country to report a COVID case late February 2020, before South Africa followed suit, Nigerian government set up a coronavirus group that should work on the issues and come out with a solution. On the other hand, South Africa took up the risk adjustment strategy, which had 5 levels, and which they implemented meticulously. On the other hand, again, Nigeria, SMOD, didn't follow that suit well, because there were politics. There were a lot of people were not buying in the way they should buy into the Nigerian case, unlike South Africa, that had an all-inclusive mechanism for everybody to be on board to discuss this. This was lacking in Nigeria. So when you look at overall the results, Africa had more success because of the method they adopted. Basically because of the flexibility of the regime type that was obvious in South Africa, unlike Nigeria. Basically, again, because of the unity of purpose of state actors in South Africa, unlike Nigeria. Basically, again, because of the increased health capacity of South African government, more than Nigeria. So in summary, quickly, before I take questions at the end, in summary, quickly, we think that crisis management plans should be adopted by all African countries in readiness and preparedness for such pandemics that could happen again or resurgence of another wave. Thank you very much. I'll stop at this. Thank you, Elizabeth.
Yeah, thank you very much. Kanayo, great presentation. Scott?
Yep. And our next speaker is a PhD candidate in public health and political science at the University of Michigan. And she's a WHO young professional. Her research interests include the comparative politics of public health, policy responses to the spread of communicable disease, and the political economy of medical devices, pharmaceuticals, and vaccines regulation. And she is one of the many who's been swept into the vortex of COVID-19 research and contributed a lot to our understanding of it. Sarah Rosenblum, please take the floor.
Thank you very much, Scott. And thank you for inviting me and for your remarkable editorial work for this great book. So I'm going to be presenting France's response to COVID-19 in 5 minutes, which is a challenge, but those who preceded me did a great job. So I'm going to try to do a great job as well. In early March of 2020, when COVID was spreading in France, President Macron posed as a military leader at war with the virus and embraced a very martial rhetoric throughout the crisis. Very early on, France centralized the management of the crisis through a series of laws that allowed the government to rule by decree for several months, and it's still the case that the government can rule by decree. A lot of strategic decisions were taken within a defense council that is usually mobilized and convened in case of war or terrorist attack. And this defense council is composed of experts discretionally picked by the president, and the content of their proceeding is kept confidential. So there was a lot of opacity and sort of mystery surrounding the COVID-19 decision-making process, which was highly centralized in the spring and summer of 2020. What's also very interesting in the French case, and that's something that I'm especially interested in as a PhD candidate, is the fact that France has a lot of public health agencies devoted to health security. And these agencies were underutilized by the government. The government chose to establish its own sources of expertise by creating different committees tasked with formulating scientific recommendations to the government. When it comes to social policy, this is one of the core topics that we're interested in investigating in this book too, is France was very generous and activated as a safety net and welfare state to protect vulnerable people, workers, families who were struggling because of COVID-19. So the French government ensured income replacement for those who had no choice but to stop working. The government also provided financial assistance and housing protections to students, migrants, homeless people, families with a lot of children who were struggling. So they definitely embraced a very sort of a generous approach when it comes to social policy. But this sort of mitigated the impact of COVID-19 on people's daily life, but there were other aspects of the government's response that prompted criticisms. First of all, the fact that the French response to COVID-19 was delayed, tardy. I wouldn't say the government was denying the fact that COVID-19 was spreading, but they lacked surveillance capacity and surveillance tools to understand how the virus was spreading in France and in our overseas territories. And the government struggled to have data on the spread of the virus in nursing homes as well. So there was basically like a lack of understanding of what was going on. And this explains why the government mobilized and activated its flu plan and hospital plans very late. And they decided to uphold a lot of events like the municipal elections that happened in March. They decided to uphold a series of religious events as well, even though we realized later on that they catalyzed the spread of the virus in France. Another interesting thing to keep in mind in the case of France is the fact that the governance of the crisis was highly centralized, and the government really embraced a one-fit-for-all strategy. They did not really pay attention to what was happening at the regional level. They lacked the capacity to understand what was going on at the regional level, and they sort of very centralized and national approach, which led to the implementation of 2 lockdowns, national lockdowns in March and October, and another one in March of this year, 2021. But these approaches were not entirely justified because at the time the virus was not spreading everywhere in France, and this centralized and national approach was really criticized by local authorities and regional authorities. And these initial missteps or errors or strategic decisions that were not quite approved of by many regional local actors prompted the creation of parliamentary commissions, inquiry commissions, and led the government to embrace a more regional approach in the summer and the fall of 2020. What is important to keep in mind, this is maybe what I want to emphasize on because I don't have a lot of time, but the fact that France was unable to deploy a contact tracing strategy and a very key triptych of testing, tracing, and isolating patients the way, for instance, South Koreans were able to do, where they were able to mobilize a lot of case investigators, contact tracers who were really deployed on the ground to understand how the virus was spreading. France was not able to do this and is still to this day not able to understand how the virus is spreading, which is quite astonishing for a country which prides itself in having a very efficient healthcare system and a quite dense network of public health institutions. I will maybe conclude by just emphasizing France's vaccination failure and the fact that France really sort of fell behind in the race to vaccinate its population, in December, January, February, and France also was sort of constrained to abandon the Institut Pasteur's vaccination trials, which involved vaccine based on measles jab. There were a lot of experiments going on to develop a French vaccine, which ended up failing, which is also another thing which should prompt maybe a reorganization of the French public health system, or at least raise interesting questions for the future. Thank you very much, and happy to answer questions at the end of this panel. Thank you.
Thank you very much, Sarah. So now I'll introduce our next speaker, Rebecca Y., who's a PhD student in the political science department here at the University of Michigan and a Leiber-Thal-Rogel Center for China Studies doctoral fellow. Her research focuses on environmental politics, specifically how citizens and bureaucrats solve collective action problems regarding water distribution in South and East Asia. Rebecca?
Hi, everybody. Thank you so much for coming to the roundtable, and thank you so much to the editors for inviting me to write a chapter on my home country, Singapore. So some of you might know, Singapore was initially held up as a gold standard of how to deal with infectious disease crises, because as Holly outlined, they were able to do all the right things. However, they very quickly saw a dramatic rise in cases, specifically in a migrant worker population. So why was this the case? Well, the main takeaway from the case study of Singapore is that we should not ignore civil society's role in mitigating public health crises because they play a vital role in bridging the gap between government and marginalized populations. So what happened in Singapore? As I mentioned, at first there was a strong coordinated response that kept cases low, and they were able to avoid lockdown. This was because they had the capacity to monitor and mitigate the spread of COVID-19 through public health and social measures. They had great capacity to contact, trace, and test cases, and they also provided social and monetary resources to those who could not work and move around because of COVID-19 so that people could stay at home. However, in March of 2020, they saw a dramatic rise in COVID-19 cases, especially among the migrant worker populations that spread to general populations, and this led to the strict lockdown of the whole of Singapore of all non-essential facilities. So why was the government not able to identify and prevent the spread of cases in March of 2020? Well, to explain this, we first need to explain why they had such a strong response at first. So Singapore is an electoral authoritarian regime, which means that even though they have electoral institutions, there is no meaningful contestation of political power. And the ruling party has had a supermajority in the parliament since the independence of Singapore. They were able to develop strong state capacity, which allowed them to enact strong public health measures, and they also curtailed the rights of the individual rights of Singaporeans. This can be seen in the public health context when they enacted harsh punishments for people who flouted public health rules, like stripping permanent residencies and visas from non-citizens. Despite this, there is high trust among Singaporeans in the government. Therefore, when when the government enacted these public health measures, Singaporeans were willing and quick to follow these measures, in part because they knew the government would provide social and monetary resources for them in this environment. However, migrant workers were not treated the same. They were treated as second-class citizens, and they were not privy to the same kinds of resources that the general populations were privy to, despite making up about 1/5 of Singapore's total population. For example, when Singaporeans were tested positive for COVID, they were immediately sent to the hospital, even if it wasn't a severe case, and they were provided free hospitalization and testing. However, it came out that when migrant workers went to clinics with symptoms of COVID-19, they were not given further medical care and testing. Instead, they were sent back to their migrant worker dorms, which led to a spread in COVID cases among the populations. This was exacerbated by the fact that the government kept civil society intentionally anemic, because they felt like they could monitor and address all the needs and demands of society without civil society organizations playing a role. This meant that they narrowed the civic space by restricting political activities, especially among the migrant labor movement, because of its contentious history. This meant that civic organizations really only focused their efforts on volunteer work and public education, and not for advocating for the rights of migrant workers and laborers. So even though these organizations had suspected that this would happen, and they actually tried to communicate it to the public and the government, because the civic society space was restricted, and the channels between these civic organizations and the government and public had not had a chance to develop, the government could easily ignore them. And this led to a blind spot in the government's handling of the pandemic, and led to this dramatic rise in cases. So to reiterate, what we can learn from Singapore is even if countries do everything right and they develop strong public health and social capacity, this is not going to work unless these resources are extended to all populations, including marginalized populations. Also, it's really important to not ignore civil society's role, even in strong states, because they play a vital role in bridging the gap between the government and marginalized populations that often do not have the same political access and influence as citizen populations. Thank you so much for listening. I'm happy to answer questions later.
And thank you, Rebecca. Our last speaker, from a country that isn't always the great happy story of a long sequence of stories in comparative politics. Our last speaker is a joint PhD student in the Departments of Health Management and Policy and Political Science at the University of Michigan. And she's affiliated with the Center for Southeast Asian Studies at Michigan as a FLAS Fellow studying Vietnamese language and society. Her research interests focus on health and development in the Global South, with a special interest in the political economy of food in Southeast Asia. Please welcome Emma Willoughby.
Hi, Scott. Thank you. And hi, everybody. Thank you so much for having me. So I'm just going to get started. Vietnam became a leader in combating COVID-19 among its populations, and as mentioned, is quite surprising to everybody. But the single party state was able to keep infections among 97 million citizens very low, using a kind of predominantly preventative, low-cost public health strategy. I think in some ways that we were talking about earlier is the ideal model that most countries failed to implement in the COVID pandemic. From the case of Vietnam, I wanted to highlight three major components to the story. First, there were streamlined state measures. Second, there was predominantly preventative health policy. And finally, to bring into the social policy element, there was actually very limited support for people, which many citizens are now facing with continuing economic crisis. So I'll just overview the streamlined state measures. The single party state helped facilitate a lot of the consistent messaging and carrying out of the health policy that happened under their directives. Also, taking very early cues from suspicions about a virus circulating in China very seriously, the Vietnamese government did not hesitate to carry out targeted practices and policies, including state-run media, communicating about hygiene and distancing, performing extensive contact tracing, identifying all suspected contacts and cases of COVID. They didn't rely on high numbers of actual testing, unlike other Asian countries. And closing all borders and directing all repatriated persons to state-run quarantine facilities. Even still today, the borders to Vietnam remain tightly regulated. So thus, isolation and suspected COVID cases was more accurate, thorough, and ultimately required lockdown for less people throughout the country. the country really only experienced 15 days total of lockdown. And beyond that, as outbreaks did happen, the quarantines were really limited to streets, villages, and in the worst case, in August, there was a larger outbreak in the city of Da Nang. Now I want to talk about the preventative health policy strategy. So as we've all discussed, mask wearing is more commonplace in Vietnam regardless, because they do suffer from pollution challenges. So the flip side is that probably helped slow some airborne transmission of COVID. The border closures and isolation meant that Vietnam successfully prevented a massive outbreak of COVID from ever happening. And this was very important for the Vietnamese policymakers. They knew that the country could not afford it. They don't have the medical technology to combat that. Additionally, the cases were limited to urban and suburban areas as well. It didn't spread out to the remote areas of the country, which meant that these clusters were concentrated near the bulk of the country's healthcare resources that they do have. Another component was the human resource capacity that was facilitated through party-affiliated organizations, mobilizing medical workers and medical students, and using the military to carry out directives and sanitation efforts throughout the country. And like I mentioned, this preventive strategy is really important because while the Vietnamese healthcare system has improved over the years, they've seen massive economic development in the country in the past 2 decades. Healthcare infrastructure does remain quite limited, and people throughout the country do struggle to access healthcare facilities equitably. And I'll just talk briefly about the social policy component here, because I think this is important for the future of Vietnam. As countries try to reopen or can't reopen, economic shutdown wasn't really a big factor in Vietnam. Actually, because the country is has such a big manufacturing sector, Vietnam was actually making ventilators and masks and sending it to other countries around the world, while other countries were suffering from COVID-19. But the flip side is that about 50% of Vietnamese workers are reliant on the informal sector, largely linked to tourism. So this means that upwards of 30 million Vietnamese people are facing unemployment or underemployment. And honestly, while the Vietnamese government has promised an aid package, a lot of people have reported they haven't received any of that payment. So to conclude, while Vietnam did not face similar restraints on work as other countries have done that had larger COVID outbreaks, the country is still facing massive economic challenges. So I think it's this case of what can we learn from Vietnam? What do we learn about Vietnam? In this case, we actually saw the Vietnamese government buy in early on to the threat of the pandemic and was very transparent in their health communication with the public. So I think we learned that population health can be made a priority of the Vietnamese government. And I have to ask, will this continue into other areas besides COVID response, other areas of public health, or even other areas of governance? And what can we learn from Vietnam, maybe as a country insights? We should recognize, I think, that in the context of COVID-19, especially positioned on the southern border of China, Vietnam had a unique advantage and was well positioned for drastic measures led by the single party state that could work to strengthen government legitimacy. I think the government has gained a lot of support from citizens in combating COVID-19. The pandemic provided an opportunity for the Vietnamese government to apply its tools and ultimately protect human lives, but challenges regarding social welfare remain. So with that, I'll conclude. Thank you so much.
Thank you, Emma. All right, so I just have a few concluding thoughts before we get into the roundtable aspect and hopefully answer some of our audience members' questions. So please put them in the Q&A and we will get to that shortly. So as we were wrapping up, well, even in the summer, it really became clear that a lot of countries weren't doing very well with their COVID response, right? And it led me a lot to think about, how can we, what is a takeaway message? And it took me back to thinking about Lev Tolstoy's opening line of Anna Karenina, and his comment about families really apply here to our case studies on countries. All happy countries are alike in their response to COVID-19, but each unhappy country is unhappy in its own way. So there were very few happy, successful countries at the end of 2020. Emma just talked about Vietnam, which was one of the few. And some of that we saw really was by having robust testing, tracing, isolation systems in place, and quick, robust implementation of non-pharmaceutical interventions. But more so, we see that there are many examples, and the book highlights numerous ones of these unhappy countries. And so it becomes really interesting from a comparative politics and thinking about public health implications to think about there were a lot of ways to really mess up the COVID-19 response. And for many of them, it was actually it was quite unexpected as well. But I will draw back to thinking about something that both Scott and Holly mentioned, and all of our panelists have talked about in their specific case studies, as we see that an effective response really meant that we had a good health policy response coupled with good social policy response, and that the two are very interdependent, right? You can't have people or expect people to comply with strong public health policy restrictions if we're not allowing people to have money to feed their families, businesses to stay afloat, et cetera, right? We need good social policies as well. We also see that while public health infrastructure was important, if you didn't want the country to have a very poor response, it wasn't enough, right? And so this is where we start seeing countries that would have been expected to be ready to fight a pandemic, like the United States, right? But we see that it wasn't enough. And we see this, for example, in many of the countries that we've talked about today and that our colleagues write about in the chapters in the book. And this was public health infrastructure was not enough to overcome bad policy decisions and poor leadership. And so we can see that, for example, with Trump in the United States, Bolsonaro in Brazil, Putin in Russia, and we also see a big takeaway message is that political institutions shaped the policies that happened. Leadership, how leadership styles, the lack of leadership really mattered in the COVID-19 response in 2020, and arguably continues to matter in how the continued response to COVID, and as Sarah mentioned in thinking about vaccination efforts. So some countries fared quite well, maybe even surprisingly well, but have since been hit hard by subsequent second or third waves. And we can think about countries in Central Europe, for example, which you can read about in the book as well. And we also draw attention to thinking about politics are evidently continuing to plague vaccination efforts, and that global inequities are being recreated in the COVID-19 response in 2021. And our final takeaway message is that we continue to argue that government responses to COVID-19 need to be understood. We thought about how they needed to be understood back in February and March. We talked about how it was almost exciting to do this work while it's also challenging to try to write about the chapters as a pandemic is unfolding, and thinking about how are we going to are we drawing lessons maybe too preemptively. But we have seen by the great chapters in this book and in reflection since, and panels and presentations about it, that the responses need to be understood and lessons need to be drawn. It allows governments to pivot and change strategies to have a more effective response to COVID-19. And I would also argue that it's important for thinking about how we can respond globally to ongoing pandemics like tuberculosis or HIV/AIDS, and for future pandemics, which we are certain that there will be more. So I'm going to end there, and I want to open it up for Q&A. Just put up one more time our table of contents and the list of great authors that have contributed to this around the world at many institutions. We've highlighted a few of examples based on authors who are based at, here at Michigan, but we look forward to hearing more as other authors present their chapters. And I'll flash up one more time. Thank you again for the International Institute for your generosity in supporting this initiative to make the book open access, and that you will have the links both for downloading your copy for free immediately, and if you want to have it as a heavy book, you can also get a discount on that. But please read it, share widely. The open access is open to anyone, anywhere in the world. So for the people who are participating, please share the link with your friends who couldn't be here today.
Okay, and I'll read the first two questions, which both came from David Ngendo Tashimba. I hope I didn't butcher your name. And one's about Singapore and one's about France, but I think they're issues that we should all be able to chime in on. And he asks, what did civil society do or fail to do to mitigate the COVID-19 crisis in Singapore? And what does Singapore's, quote, electoral absolutism, its regime, teach us about governance in pandemic times? Is such electoral absolutism a worthwhile thing to consider or to abhor? And the other is about France. What was the focus of the Pasteur Institute in the wake of the COVID-19 outbreak? Is scientific discovery too contingent depending on the politics of the day? And if so, who should be governing in pandemic times such as these? So thank you for a couple of really nice meaty questions there. If Rebecca could take it, and then Sarah.
Thanks so much for your question. So what did the civil society do or fail to do? Well, at first, because as I said, the civil society space was kept anemic, they couldn't really do much because the channels were not developed between them and the government yet. However, once once COVID hit the migrant worker populations and the government realized, oh no, we kind of don't have the capacity to deal with this, they started working a lot with these civil society organizations because they had developed the capacity and the knowledge of how to work with migrant workers in terms of like translation, in terms of like where the dorms are. And this kind of goes to the second question. Electoral absolutism shows that, you know, the government can't do it all. That's just it. There will be blind spots, and it's really important to develop partnerships between the government and of citizen spaces. However, it's also important to note that as soon as the government knew that there was a spread in these populations, they were able to mobilize really quickly. They had a political will, they had a capacity in order to like lock down the whole country and start providing resources, testing capacity to these populations that were hit. Thank you.
Sarah?
Yep. Thank you very much for your question. I think when it comes to l'Institut Pasteur, Institut Pasteur and Merck were developing a vaccine based on measles jab, but I think they had to give it up because patients who participated in the trials did not develop enough antibodies and their immune system response were too weak to be satisfying, and which is a disappointment for what is considered to be the best, public health institute in France. And Sanofi is also developing its own vaccine, but I think there are delays, and the vaccine won't be available in the fall if the results are satisfying. So it's really a blow to France, I would say, public health prestige and France's efforts to contain the pandemic. Now, to answer your second question or third question, which is, I think, very interesting and also very challenging, and I'm not gonna, exhaust all the answers now, but who should really govern in pandemic times such as these? We have different scenarios or different cases. We have countries in which public health experts were put at the forefront of the COVID-19 pandemic, like in Korea, for instance, which is a country in which I'm really interested in, and one of the chapters is about Korea in the book. And they were able to deploy very efficient testing, tracing, and isolating COVID-19 strategy. You have other countries in which public health experts were also put at the forefront of the COVID-19 response, and their strategic decisions were not necessarily the best. You can look at Sweden, for instance. So I'm not saying experts should govern in times of crisis. They don't have any accountability. They're not elected by the people. But I'm saying there are definitely different scenarios which led to different outcomes. And it's interesting to look at the choices that were made by governments to more or less mobilize their pre-existing public health agencies, to create new agencies, or to sideline those agencies and to understand the reasons behind those choices. So I'm going to stop here. I want to leave time for more questions, but I think this is something that deserves thorough investigation, and that's something that I'm personally working on. Thank you.
Yeah, thanks. Should we move to the next question, which is open for any of our panelists? And We can also think about it across countries as well. But so from Cynthia Buckley, Dr. Buckley writes, thanks for the thought-provoking presentations. Might any of the speakers care to extend their remarks concerning the internal unevenness of state capacity in their case studies, either in terms of variations in capacity across social groups, ethnic or religious, or geographical space, border regions, capital cities, etc. So I don't know who wants to start with this question.
Yeah, I can jump in if there's nobody else that wants to take a stab at this. And I think it's also a very interesting question and particularly relevant for Italy, as I mentioned that there was such variation among the regions. So just to give you an example of that variation. So the region of Lombardy, one of the hardest hit regions in Italy, it used a hospital-centered approach in its sort of combating the pandemic. And what that meant is it basically brought all people to hospitals. And when the hospitals overfilled, they moved them to care homes, which then just really exponentially blew up the numbers. And what they did with regards to testing is that they followed sort of the government's recommendation of testing only symptomatic patients. And in contrast to Lombardy, another northern region that was also affected, but not as drastically because they took a different approach, was the region of Veneto. And they used a community home approach. And what that meant is they did less sending people to hospitals and more sort of in smaller communities with GPs and things like that. And they saw a lot lower cases in that region. And they also did not follow the government recommended sort of testing strategy of testing only symptomatic patients. Rather, they went their own way and they tested both symptomatic and asymptomatic patients right at the beginning and were thus able to sort of curb this explosion of cases quite quickly and keep the numbers down in that region.
Would any other panelists like to talk about this, reflect on it? No, it came out in several of the chapters. So.
Can I add a word maybe on the French response or when it comes to ethnicity, because it's an interesting case, or do we want to move on to the next question?
No, please.
So, France's approach to race, we don't use that word in French, or ethnicity is, kind of a very unique approach because we don't really have ethnic data nor racial data. And France's approach to COVID-19 was very uniform, one fit for all strategy, very undifferentiated approach. And now we have studies a year into the pandemic showing that people who were born in Africa or Asia and living in Paris or the greater Paris area were twice more likely to die from COVID-19 than their French citizen-born counterparts. So our data we didn't have early in the pandemic because we don't use racial data nor ethnic data, and this approach prevented the government from deploying targeted measure aiming at protecting what are vulnerable populations, populations who are overexposed to the virus because usually they're frontline workers. And this is an interesting case in which France, blindness to race or ethnicity was perhaps problematic and hindered the government's capacity to understand what was going on in specific areas with respect to specific populations.
Okay, and the next question is actually from one of our authors, Nina Yamanis, who was one of the team that wrote about Tanzania, which was a hell of a story. And her question is for Holly, which is, where do you see official communication, consistent or transparent outbreak response communication, preventing or facilitating the spread of misinformation in your policy response categories? It seems to me that communication could cross multiple response categories such as surveillance and governance, and is an important factor determining population compliance. So Holly, if you want to take that.
Yeah, and so Nina, thanks for the question. And one day we will get to interact in person, I hope, rather than electronically. So where I would say the kicker here is that communication is absolutely central, and it's so important across all 4 categories. And that's part of why this is so complex. So if you think in terms of governance, communication, for example, of what the non-pharmaceutical interventions are at any one time, what does lockdown look like? Some of these communications were so complex, or just not well done in some countries in terms of trying to tell people what are the expectations, what are your obligations at any one time. And also obligations in a lot of countries changed quite quickly over time. So that's a huge communications challenge. So there are communications challenges from a governance perspective for leaders and the executive, and also then subnational governments around what is the actual policy at any one time, what are the expectations, what are the penalties, as well as governments trying to communicate with other governments even within their own country. So are they actually sharing data in the right way? Is information coming to central government for use? And then how do they choose to or not make that decision process transparent to the public? Is another set of questions. But then to not to go on too long, so the other categories, surveillance communication is incredibly important for trying to explain to the public what is the current scope of the pandemic right now, where are the cases, and you see a lot of publicly available data sources, and either from government or from the media in a lot of places, but then how do you as a public health person choose to speak about that and about the pandemic to the public, hopefully in order to support compliance? And then that slides into coercion, where you're thinking about isolation, and what kind of communication do you have to give through the contact tracing process? How do you keep people at home? How do you inform people about what to do in the event that they have an exposure? And then finally, social policy. All the bureaucratic obstacles to people receiving what help they're entitled to apply here. And so governments did a very bad job, I think, in a lot of cases of explaining to people who are entitled for support exactly what that support entailed and how it was going to work. And so across all of these 4 categories, the reason communication is not an extra, particularly distinct thing is it's an activity that's central across all 4. And the challenge of the pandemic is the complexity of communication required. Plus, a lot of governments were not, I think, prepared in the context of broader outreach, particularly to some of those groups that might be much more affected, and were not as good at communicating with those groups because historically they had not been good at communicating with those groups. So you get, especially in the social policy and health policy components of this, those existing inequalities replicated.
Yeah, thank you, Holly. So I have one more question that I think actually will probably spur some other discussion beyond Europe, but Stefania writes that her question is, what steps would you take in the future in Europe for avoiding a similar pandemic? Could you summarize a couple of main steps that can be taken? So if we could think about some of the lessons learned, and we can start with Europe because that is Stefania's question, but I would also expand it beyond thinking of Europe, and if others want to chime in as well, but we can start with Europe. Scott, I think you wanted to start.
Yeah, so I was involved in the European Union chapter, and the EU broadly has had a good pandemic, because after a little burst more or less a year ago of people saying Europe was going to break up and embarrassing stories about countries not giving each other PPE and necessary supplies, something really interesting happened, which is European member states decided they couldn't go it alone. They decided that their economies were too interconnected. The desire of Germans going to go to Mallorca was just too profound. They needed to actually act together, both to prevent the kinds of restrictions on the import and export of medical goods and devices, and to prevent restrictions on the movement of people across borders specifically. Countries in lockdown obviously didn't have a lot of people going anywhere, including across borders. And also they decided to team up both to create a larger civil defense system, which would stockpile useful things for the future in order to distribute as different countries had different peaks and valleys. And they decided to go in together on vaccines. And at the moment, this is going poorly for a variety of reasons. And there's a gigantic amount of recrimination and anger and blame. And naturally, one of the key functions of the European Union is to absorb blame, some of which is justified, but much of the time it's because member state politicians need to blame somebody, and there's no one better to blame than Brussels. The EU basically has put together a vaccine strategy. It's done an enormous amount of procurement. It hasn't done it the way I would have done it, but they did it the way European Union institutions do it. And they're rolling out vaccines. Did they gain legitimacy from this? Not necessarily. Does the European Union now have a level of fiscal and health policy integration that we wouldn't have dreamed of when we were writing about EU health policy in January 2020? Absolutely. The EU's had basically a good pandemic in terms of massive expansion of what the EU does, even if it's currently justifiably getting blamed by every single European for the absence of a vaccine that suits them.
I can try to answer that as well. I wonder if this question relates to avoiding similar pandemics or responding to similar pandemics, because avoiding pandemics is especially zoonotic disease. Is that correct? Zoonotic disease requires a combination of environmental policies and health policies, and it's different. What we discuss here is more responding to pandemics. And I think one thing that we point in a book is that state capacity is a necessary condition, but it needs to be used. So, and we also suggest some of the politics involved, and I think we discussed that better in the conclusion. Just to be short, because I think we are running out of time, almost running out of time.
I wanted to also add some of the more obvious things perhaps that may not need to be said, but I'm going to say them anyways. For specific countries, I think, as we've heard, an updated pandemic plan, a functional pandemic plan might be beneficial. Increased investment in public health, the health sector is also something that could help in future pandemics. Also, really important is sort of this cross-sectoral working together with other sectors, working together with the Minister of Finance, working together with a Minister of Environment and things like that, I think is increasingly helpful. And I think a lot of countries have kind of come up, kind of realized that. And another thing in the midst of a pandemic, I found also in Austria, Switzerland, Germany, neighboring countries of Italy, to be a crucial point was communication strategy. And it's something that Holly mentioned previously. Clear messaging, clear communication is always really helpful during a pandemic and during any crisis, for that matter.
Okay, and we have two more questions, which I think exhausts what we can do with our remaining 5 minutes. And one of them is very short and simple, and it's about Vietnam. And it basically says, what should we learn from Vietnam? What can we expand from, what can we extract from the Vietnamese experience that doesn't require adopting the entire Vietnamese state structure and political economy? So I think that's kind of a question a lot of people in the world want to ask. And then for our last question, we'll be open to the panel about economic policies from Marie.
Okay, I'm going to try to answer this question as best I can, because I think, at least going off of with European discussion on coordination and of these like policies between agencies, Vietnam was really able to do that because it's such, it's a hierarchical party-led government. So I think maybe I think one of the big strengths with the Vietnamese cases is honestly the border closure. And that happened early on. And I think that really helped limit any kind of potential spread in the country. The cases that then came in later were kind of seemingly undetected by people returning home on flights or workers coming through a border that people weren't aware about. And like I said, even still today, the border is so tightly regulated, but what's gained in return is that Vietnam kind of has gone back to normal, except that you can't be a isolated kind of hermit nation successfully. So, but I think, yeah, maybe a key takeaway is acting fast, and also isolating people, any suspected kind of cases that came in contact with COVID. But I think we also learned that, you know, you can do this with lower cost if you can prevent the spread of any outbreak.
Yeah, great. Thank you, Emma. So I'll just ask our last question probably before we wrap up. And Marie writes that she's wondering about the role that economics policies related to tax, labor, and credit played in the pandemic. Did compliance with COVID-19 measures, was it higher among countries that were more generous at creating tax exemption policies or providing more financial credit? And I think Elise, you wanted to start with that, and if people want to chime in, but.
You're muted.
Sorry. I can talk about what she asked the primary care workers in Brazil. Why the non-optional local capacity? Well, I think what happens with primary care in Brazil is that we have a very different state capacity among different regional governments, and some regional governments were able to mobilize primary care better than others, and this is something that we point out in the conclusion of the book. We need more case studies of regional governments to understand why did that happen.
Great, thank you, Elise. So it looks like we're wrapping up, and I'll turn it over to Scott to say a final parting thought. But I just wanted to say thank you to the participants who joined us. And if you have more questions or you wanted more information on your questions, you may also email us at coronaviruspolitics@umich.edu, and then we will get it to the appropriate authors to respond to those questions. So thank you very much. And thank you once again for the International Institute for hosting us.
And as ever, the Q&A function in the chat has really started humming. So I'm trying hard not to be distracted by answers to the good questions that came in the last 5 minutes. Anyway, I once again want to thank the International Institute and the University of Michigan Press for working on this. I'm involved as a minor author in one other 650-page academic book, and let's just say it's taken more than 5 years with 2 full-time paid research assistants, and they still haven't got the thing through proofs yet. So we could only do this because the University of Michigan Press, the University of Michigan, and our wonderful authors worked with us, delivered great stuff, often involving learning a lot, on what for academics is a ridiculously short schedule. So I thank you all for coming. I encourage you to download the book for free. I encourage you to use that sweet, sweet discount code for a 30% reduction in price, UMS21 on the website. And otherwise, it's 1:30, and I hope you have a good rest of the day.